Commissioners, we are now live.
Good afternoon, and welcome to my fellow commissioners and also to members of the public who are tuning in online. This is our first public meeting of 2025 and the first since the signing of two very significant healthcare bills, which make a number of important changes to our responsibilities moving forward. So, number of changes to the Health Policy Commission's oversight responsibilities. We will be discussing that new legislation as one of our major agenda items. I want to start today's meeting with an important introduction. Since our last meeting, the state auditor, Diana DiZoglio, appointed Karen Coughlin to the HPC board to fill the seat for a registered nurse with demonstrated expertise in the development and utilization of innovative treatments for patient care. We're delighted to welcome Karen Coughlin, who has been a registered nurse for over 40 years, many of which she spent working at Taunton State Hospital. And she's also been engaged in the work of the Massachusetts Nurses Association. So we're very glad to have her join us on the HPC board and provide her perspective and breadth of knowledge to our work. And can I ask you, Commissioner Coughlin, to say a few words about yourself? Oh, you're on mute.
Yeah. No worries. As you had said, I have been a registered nurse for a little over 40 years. I spent my entirety of my nursing career working at the bedside for the Department of Mental Health. I have been involved with the Massachusetts Nurses Association. I was their vice president on the board of directors for well over 10 years. I currently continue to sit on the board of directors, but I am no longer an officer of the MNA. I am the president of the Northeast Nurses Association, which is a collaboration between Massachusetts, Pennsylvania, the PASNAP nurses, Rhode Island, and a newly formed union in Rochester General in New York. The purpose of that association is specifically to organize healthcare workers in the Northeast region. That being said, I am the chair of the Workplace Violence Task Force. That is an issue that I am very passionate about. I have advocated for years for changes to be made within the healthcare workforce setting in order to minimize the risks of workplace violence. I also have advocated for patient services starting, it was early on in I believe it was 2012, 2013, when they were looking to close Taunton State Hospital, worked with community groups, legislators, et cetera, to stop the closure of Taunton State Hospital at the time. It was downsized from its original capacity, but we were able to save some of those services in the Southeast area. That being said, I sat on a legislative committee related to behavioral health care access in the Southeast area. And we had a report that was generated that was related to recommendations for mental health behavioral services in the Southeast area. And then I worked with CHIA on a panel as well related to mental health access and where the gaps were and boarding in the emergency rooms, et cetera. So I'm very excited to be on the HPC as a commissioner. I really do look forward to working with the other commissioners, and I am hoping that I will bring a perspective to the board that reflects the direct care bedside workers and what they are seeing on the ground. Because as I continue to work in the setting as a retiree now, but in the setting, I still meet with nurses from across the Commonwealth in a variety of settings. And so remain up to date and knowledgeable related to what we are seeing at the bedside. So I'm very happy to be here. And so thank you for allowing me the time to speak.
Thank you. Terrific. Look forward to all of that experience being brought to our work, and thank you so much for serving. So let me begin the meeting today by reviewing the 3 agenda items that are the majority of our work today, and then we always have an executive director's report as well. So the 3 topics are: first, a report out from the HPC's new Behavioral Health Workforce Center. Second, a presentation with an overview of the healthcare legislation recently signed into law by Governor Healy and the impact of the legislation on the HPC. And that presentation will be done by Executive Director David Seltz. Then members of our research department are going to present new data on access and spending trends for primary care workforce in Massachusetts. And we're going to discuss some policy recommendations to alleviate these challenges, as well as next steps. We'll then conclude the meeting with agency updates and our executive director's report. So the first order of business before we jump into those agenda items is to vote on the minutes from our last board meeting, which was December 12th, 2024. And let me turn it over to our Deputy Executive Director, Colleen Elstermeyer, to lead us through that vote.
Thanks so much, Madam Chair. Good afternoon, everyone. If there are no amendments to this set of minutes, I would ask for a motion to vote.
So moved.
And a second?
Second.
Thank you. And I will ask each commissioner present to vote, starting with you, Chair DeVoe.
Aye.
Vice Chair Cohen?
Aye.
Commissioner Castile?
Aye.
Thank you. Commissioner Coughlin, we are asking you to abstain as this is your first meeting. Thank you so much. Commissioner Cutler?
Aye.
Commissioner Foley?
Aye.
Commissioner Haupt?
Aye.
Commissioner Mastrogiovanni?
Aye.
Commissioner McGregor?
Aye.
Commissioner Sullivan?
Aye.
Thanks, Dana. And Undersecretary Mahania?
Abstain, since the secretary herself was here last time.
Thank you so much. Okay, back to you, Madam Chair.
Thank you. Thanks all. And let me introduce our Executive Director, David Seltz, who will tee up our topic on the Behavioral Health Workforce Center Advisory Group.
Thank you, Chair DeVoe. Good afternoon, commissioners. It is wonderful to be with you here at the beginning of this year. We have, as the chair said, a very exciting agenda and a lot to update you on. There have been some really exciting developments in healthcare in Massachusetts since the last time we met. And one of those exciting developments has been the continued progress that the Health Policy Commission has made in the development of our Behavioral Health Workforce Center. This Behavioral Health Workforce Center, as you know, was established last year with support from the Executive Office of Health and Human Services, and is really being set up to address a significant challenge in our healthcare system related to the pressing need to address challenges specific to mental health and substance use disorder workforce. And you have met the director of this workforce center at a previous meeting, Amy Doyle. So I'm just going to turn it right over to her for an update on the work of the center.
Thanks, David. Good afternoon, everyone, and welcome, Commissioner Coughlin. Really glad to have you on board and appreciated the sentiments you shared about behavioral health and the workers. I think a lot of that resonates with myself and our team. So thank you, everyone. I'm really excited to be here to reintroduce you to the center and share a couple exciting updates. As David said, we launched just several months ago in partnership with EOHHS, and we have been working to build up our center to lead statewide efforts to strengthen the behavioral health workforce center across the behavioral health workforce across Massachusetts, really leveraging our stakeholder relationships and cross-sector partnerships, and ensuring that we're hearing from everyone out there who's already doing some really valuable work in this space. and trying to build upon some of the work that's already been done. And I will add a quick update just internally for our team. The last time I was here with you in September, I was the first and only staff member, just a couple weeks into the role as director. And now, just a couple months later, we are an awesome team of 4 people strong, which is very exciting and is really helping to drive this work forward. So next slide, and I will share our biggest news, which is that we launched a procurement process in early October to identify members of our inaugural Behavioral Health Workforce Center Advisory Group, which will really be asked to share knowledge and expertise to inform the critical work that our center will be doing over the next few years. We received a truly overwhelming volume of responses to this procurement process and completed a comprehensive internal review. This led to the selection of an incredibly talented, diverse, and highly experienced group of providers, patient representatives, industry experts, and policymakers who will be meeting with us at a minimum on a quarterly basis, and maybe asked to do some additional topic-focused work as we continue on with our portfolio and identify some of our top priorities. I wanted to give a special thank you to Commissioner Cohen and our internal review committee for their dedication and support of this process. It was took quite a lot of time, and we're very excited with the result. Our first meeting is going to be Tuesday, February 25th via Zoom, and we look forward to sharing more updates once we get together and can share a bit about our agenda and what we think the work will look like over the next 18 months that we have asked this group to commit to engaging with us. And with that, if we can go to the next slide, I am very excited to introduce all of you to the members that were selected for the first iteration of this group. There are some familiar names, I think, to the HPC and some of the commissioners here, and some new ones as well. And we are just truly excited to begin getting to know this group, learning from them, hearing about both work experience, training, education, and also lived experience. We have a few folks here who applied to share their experiences as caregivers and members of the community with lived experience navigating the behavioral health system. And I think we really are proud of the group that we were able to identify here. So like I said, our first meeting will be February 25th, and I look forward to coming back and sharing updates in the future.
Great, thank you so much. Any questions, Commissioner Coughlin?
I do have a question. So when I take a look at the 30 members, I am surprised that there is no one specifically like direct care workforce, like from DMH, that serves a very large, number of patients within the Commonwealth. And honestly, I would have loved to, I don't know what the vetting process was or the procurement process was, so I can't speak to that. But I do know that oftentimes what ends up happening is that oftentimes we have administrators who serve on advisory groups, et cetera, from various settings, and we don't have any direct care workers, though it does look like, I'm sure that some of the social workers, et cetera, that, are sitting on this and, some peer support, that's fabulous. But I was a little disappointed not to see anyone from such a large setting, because some of these, they're overseen by the Department of Mental Health, but we do have a large, patient population within DMH. And so that would be great if we had someone from that arena.
Yeah, thank you. I appreciate that feedback. I will quickly share and then toss it over if Colleen or David, if you'd like to add anything. We actually did make a very intentional decision in the beginning of the procurement process to ask that state employees do not apply to participate, given that we are working in such close partnership with our state agencies and are very engaged in meeting regularly with folks from DMH, DPH, Mass Health, and our other sister agencies. So given that, potential conflict of interest and close collaboration with them, we actually made the decision to try to have just non-state employees in this group. And we do have several members who are currently providing direct care in their roles, but definitely hear those concerns and appreciate the feedback.
And while I do appreciate that, I would say also that sometimes you have a different perspective from the direct care workforce than you do from the administrative, staff at the agencies.
Absolutely.
I would just add, Commissioner, that we would love to engage you directly in this work. We have just begun this center 4 months ago, so I think this is a really great time to get you involved and have you help and consult us on this. So we appreciate that. Thank you.
Good, thank you. Other questions or comments?
I have a quick question. Just curious, and I can follow up offline. Is there anyone who works at the intersection of maternal health and mental health on the board this time around?
Yes. The member who most directly would fit that role is Dr. Lena Mittal, who has been working for MCPAP for Moms the last several years. I believe she is an OBGYN, but the primary focus of her career has been maternal and perinatal mental health.
Excellent. Thanks so much.
Well, good to know. Any other questions or comments from commissioners or any last thoughts? Amy?
That's it for me.
Good. Well, we will look forward to this. Oh, I'm sorry.
If I may, I'm sorry,
Yes,
my hand goes up and then it goes down. I just wanted to say that just looking over it, and I think this is great. I think sometimes we leave Central Mass out and certainly some of the smaller areas and certainly, our struggles here and our struggles in smaller towns are important to hear, and they're very different than what happens in Boston.
Yes, I appreciate that feedback as well. And we can share actually some aggregate data about this group, but we did in the review process take a very close eye to demographic and geographic distribution and made sure that we had representation from all of the 5 major regions of Massachusetts. And we do have some from the smaller towns in northern, central, and western Massachusetts, and a couple who also their catchment area includes folks on the South Shore and Cape and the islands.
Very helpful. And yeah, that would be, I think, useful for the commissioners to understand another layer of detail about the kinds of backgrounds and lenses that the different members have. Great.
We can definitely share that information.
Any other questions or comments? And if I'm not seeing anyone for any reason, please just speak out. Don't wait for me to recognize you because I can't see all the commissioners simultaneously, so I need to scroll up and down.
Okay. And I'm actually, if I may, let me make a quick correction, because when I spoke to Dr. Lena Mittal, I said I thought she was an OBGYN, but then I wanted to fact check myself. She's actually a psychiatrist who works with the OBGYN department and with new mothers. So just wanted to make that quick correction.
Great. Well, thank you so much. It's exciting to begin this work, and we will look forward to future progress.
Great, thank you.
So we'll now move to our next major agenda item, which is the overview of the new healthcare legislation and how it relates to our role and responsibilities. And I'll turn it over to Executive Director David Sells.
Thank you, Chair DeVoe. So excited to be able to share with you some meaningful progress on legislation that occurred over the holiday break on the waning days of the legislative session. This commission has been following this legislative session very closely, and some of the significant pieces of legislation that were under negotiation throughout the past 2 years. There were two significant pieces of legislation that were really in conference and being negotiated really up until the last minute, that we were tracking particularly closely, as they had significant implications for both the Health Policy Commission, but more generally for the healthcare system and for oversight of the healthcare system in Massachusetts. Before I dive into these two bills, though, I do want to note that the legislature in this past session passed a number of significant healthcare bills. And while I'll be speaking specifically to these two, I do want to note and recognize that there were legislation on maternal health, legislation on substance use disorder, legislation on cancer screening. I could go on long-term care. I could go on and on, but there was just an incredible amount of thoughtful activity by the legislature in this past session. Many of these bills do include some work for the HPC, and we are diving into all of them and trying to understand exactly how we engage with all of them. But these two bills in particular are quite sweeping and quite meaningful, and are really intended to strengthen this Commonwealth's oversight of the healthcare market and address rising drug prices. These two bills they came to a final agreement, as I said, in the final days of the legislative session, and were advanced to the governor. And as you can see in this picture here, the governor signed these two historic pieces of bills on January 8th in a very well-attended and celebratory ceremony at the State House with representatives from across the healthcare industry, advocacy community. I do want to just also take a moment to applaud the leadership of Speaker Mariano and Senate President Spilka for their work in making sure that these bills were advanced to this final stage. And particularly Chair Lawn and Chair Friedman, who were working on these bills for so long and up until the last minute to try to find those compromises, to find the path forward, and always, I think, prioritizing what's best for the Commonwealth and how to really make meaningful progress. And I will say, in our estimation, these two bills represent the most meaningful and significant advancement of healthcare policy since the passage of 224 in terms of our state's oversight authority, our cost containment efforts, and an expansion of our oversight into pharmaceutical pricing in particular. So I'm going to spend a few minutes just walking through some of the major provisions of these two bills. Commissioners, I invite you to ask questions along the way. I'm going to do a few slides. I'm going to ask members of the HPC staff to also present on a few of these slides as well. I will say also at the top that we are still diving into these bills and trying to continue to understand what the implications will be for the HPC, for the operations of our agency, and for the staffing of our organization. And you can expect that I and the staff will be back at every board meeting from here on out, talking to you about the implementation of these bills. There will need to be, I think, significant amount of work on regulatory definitions, perhaps some interim guidance along the way. So expect to hear from me early and often as we continue to implement these bills. Next slide. So broadly speaking, this slide really just kind of buckets some of the big areas where these bills make significant reforms. And these are the areas that we'll be walking through today for you. So first, I'll talk about some of the changes to the HPC board membership and governance. Second, I'll be talking a little bit about an expansion of oversight, specifically on the pharmaceutical industry. There are a number of changes to our market oversight authority that are reflective of recommendations that this agency has made, especially in consideration of this past year and the experience that this Commonwealth had with the bankruptcy and dissolution of Steward Healthcare and the need for greater scrutiny of certain types of transactions that may have significant negative harms to Massachusetts residents and communities. There's also some important new work here around state health planning and understanding the supply and distribution of our healthcare resources, and a few other provisions that we'll speak to at the end. Next slide. So first, I just want to review some important changes to the HPC board and the governance of the HPC. The HPC is an independent agency. This has been an important part of the structure of the HPC since its inception. And the HPC as an independent agency is governed by a board of experts who are determined and set forth in law in different categories of expertise and are appointed by constitutional officers. This legislation changes some of those designations as well as changes the structure of the appointing authorities. So all of these changes that I'll be walking through are effective on July 1st, 2025. So effective on July 1st, 2025, the board will go through this overhaul. And at that point, the two appointing authorities will be the governor and the attorney general. The governor, as you can see, will have a number of appointments that many of these positions continue to be positions that were on the current board, as you can see here. Where you can see in the orange text, there are some places where there are new positions or slightly modified positions from the current board structure. So to highlight those two new positions for you, there is a new position for a commissioner with expertise representing hospitals or hospital health systems. There's a new position for a commissioner with expertise in pharmaceuticals, biotechnology, or medical devices. And one of the ex officio commissioners, which was our Secretary of Administration and Finance, is now replaced by an ex officio appointment of the Commissioner of Insurance. There's an additional layer of modification to the appointment process for two of these members. So for the commissioner with expertise in representing the healthcare workforce, this is an appointment made by the governor, but that appointment is made based on a selection of a list of nominees submitted to the governor by the president of the Senate. And similarly, that new commissioner position that I mentioned before with expertise in pharmaceuticals, biotech or medical devices, that is similarly selected from a list of nominees by the Speaker of the House submitted to the governor. For the Attorney General, her three appointments are the same as they are under the current structure: health economist, expertise in behavioral health, and expertise in healthcare consumer advocacy. There are, this continues to maintain an overall 11-person board. So with the addition of two new designations, there is 2 designations that will no longer be appointed in this new structure. One is the designation for a primary care physician, and one is for a commissioner that has demonstrated expertise as a purchaser of health insurance representing business management or health benefits administration. Importantly, this new structure and these new appointments, which will be effective, as I said, on July 1st, are still subject to a very important conflict of interest provisions within our statute that go above and beyond the state's state ethics requirements, and are very important and have been a part of the HPC structure since its inception to ensure independence from industry interests. And that a conflict of interest language states that a member of the board shall not be employed by, a consultant to, a member of the board of directors of, affiliated with, have a financial stake in, or otherwise be a representative of healthcare entities while serving on the board. And that important provision remains to ensure the continued independence of these commissioners. 2 other changes I'll just mention quickly. Starting in July 1st, these new members will receive a stipend for their time. I think this is reflective of the important work of the HPC and the incredible amount of time that you all put into this work. And I think, commissioners, you can certainly testify that we certainly ask a lot of you in these positions, and I was certainly pleased to see that recognition in this legislation. And then finally, with these new appointments, there will also need to be a decision around whether the new appointments will be for 2 years, 3 years, or 4 years, and that decision will again be made by the appointing authority. So I'll pause here to see if there are any questions around changes to the HPC board membership and the appointing authority structure. Tim.
Yeah, thank you. To your last point, that's something I hadn't thought about. Is there's staggered appointments. It's the appointing authority's decision of which ones are 2, 3, or 4 that's written. I didn't recognize that part of the statute, so thank you for that. That's accurate.
That's correct. It's
okay.
Different than the original legislation, which actually designated which spots got a 2-year or which spots got a 3-year. In this case, it will be the decision of the appointing authority which of the designations will receive which staggered term.
Got it. Thank you.
Okay, seeing no further questions on this one, and certainly if you have some, we can absolutely return. We'll move on to the next topic, which is the establishment of a new Office of Pharmaceutical Policy and Analysis within the Health Policy Commission. We're going to go ahead and call this, the new acronym we're going with is OPA. We're just going to go with it. So the new Office of OPA is, I think, an important, really, really important advancement in the state's oversight over an incredibly meaningful part of healthcare spending and healthcare service delivery. Pharmaceutical spending has been a major driver of healthcare spending in recent years. Pharmacy spending for commercial enrollees grew 8.2% per year from 2019 to 2022. And it contributed meaningfully to our state's overall healthcare spending growth. Just to say that again, if pharmacy spending in our last year, where our total benchmark spending was 5.2%, if pharmacy spending had instead grown at the benchmark rate of 3.1%, the total spending would have been 4.1% rather than 5.2% for commercial spending. So this is having a meaningful difference in terms of our overall trends. And reflecting that this is a meaningful part of our overall trends, the legislature has established and authorized the Health Policy Commission to set up this new office to dive deeper into what are the underlying trends driving the spending growth. And so this new office, this new OPA office will has a broad mandate to collect and analyze spending data and produce reports with policy recommendations to the legislature and to others. There is a directive to publish an annual report, as well as an opportunity to issue reports on specific topics as well. There is a directive, a particular directive that the new office produce an annual report specifically on the intersection of pharmaceutical access and health plan design, looking at how tiering or copay or deductibles or utilization management or prior authorization may intersect with patient access to pharmaceutical drugs. Next slide. In addition to this broader expansion of oversight of the pharmaceutical industry, which, again, I would just say, is meaningful in so much as this really does bring this important part of our healthcare sector, really underneath the umbrella of transparency and accountability that all other parts of the healthcare industry have already been a part of since 2012. There are a number of other important provisions that the legislation includes, even beyond the Health Policy Commission. So one of those important provisions that will have a significant impact on patients is a provision that caps out-of-pocket costs for certain drugs identified to treat asthma, diabetes, and prevalent heart conditions. This mandate will apply to MassHealth, the Group Insurance Commission, and to fully insured commercial health plans. And the legislation asks the Health Policy Commission to evaluate the impact of this new program every 2 years. To aid in all of this new analysis, the legislation authorizes CHIA to collect additional data and information from health plans and pharmacy benefit managers that can be used by both the Health Policy Commission and the Attorney General in aid of our work in analyzing and examining these trends and making policy recommendations. Finally, an important provision specific to pharmacy benefit managers. The legislation authorizes and mandates the Division of Insurance to establish a process for regulating and licensing pharmacy benefit managers operating in the Commonwealth. And this new regulatory process will include certain licensure requirements and may include an ability for the Division of Insurance to conduct audits of pharmacy benefit managers. And if there are violations that are identified, the Division of Insurance may go so far as to revoke a license of a pharmacy benefit manager. Many of these details, I think, will need to be confirmed as this process moves forward. But I'll pause there for any questions on the expanded oversight into the pharmaceutical sector and PBM oversight. Commissioner Cohen?
David, could you just speak to how this also relates to our current mandate to look at pricing for MassHealth on pharmacies where there's a difference between the pharmacy price and what MassHealth is willing to spend, and how that meshes here?
Yeah, it's a great question. I see this really as complementary and kind of to that existing authority. So that existing authority continues to be maintained, and just to say a few more words about that, this is the current process whereby if MassHealth fails to come to a successful negotiation with a drug manufacturer on supplemental rebates within the MassHealth program, they may refer a drug to the Health Policy Commission to conduct an analysis and a review to examine the value of that drug in relationship to its price. The language does anticipate and kind of contemplates that the new Office of Pharmaceutical Policy and Analysis would be able to share information and work with those types of reviews should they happen. So I see this as complementary, and the fact that we're going to have new ability to collect information through CHIA will only really aid our ability to do that work. And so we're thinking about how these pieces will mesh together, but I see it as very much bolstering that existing authority. Tim?
Yeah, thank you. Great question. That was similarly on my mind. Just going back to OPA, which I really like the sound of that. Is there additional monies included in this bill? Do you expect new staff? Just thinking about the budget of the HPC as well, and like kind of as you're going through some of these new mandates and programs with the HPC, if you just kind of speak to that piece of it too, is we're getting more and more thrown at the commission, and I think that's an indication of the great work that you all do and that we do collectively, but also there's budget ramifications and funding. So I'm just wondering kind of how that all plays out as you're going through these new offices and the health plan and all those other pieces, kind of how it impacts the budget, and are there additional resources coming to help support those new mandates?
Yeah, it's a great question, Tim, and I'll let me speak a little bit to this now, and we'll speak a little bit more towards the financing a little bit later as well. These are ambitious mandates that the legislature has tasked the Health Policy Commission with. These are broad mandates that, even just in the case of OPA, to really dive deeper into a very complex industry, oftentimes a very opaque industry, and wanting to this center and the legislation actually envisions that this new office will be really a hub of expertise for the entire state government when it comes to pharmaceutical policy. The legislation contemplates that other state agencies that purchase prescription drugs, whether that would be MassHealth, GIC, or even corrections, that they may consult with this office, and that this office may provide expertise and consulting policy advice. And so that is a broad vision in terms of what this office may be. So yes, I do think that there will need to be additional staff and resources dedicated to these new tasks to meet the vision that the legislature has set forth here for us. And I do believe that we can meet that mandate, but it will require additional expertise. I think broadly, when we go through all of these categories, what gives me some comfort here is that each of these are building off of areas where we have a foundation. Even in this space, we have researchers and staff members on the HPC team who have been working and thinking about pharmaceutical research and analysis. We have staff who've been thinking about the program that we have with MassHealth, and as we'll talk a little bit about next on health planning and later on market oversight. These are building off of areas where, again, we have a strong foothold, but these are expansions, and to do this work and to do it at the standard that you expect of us, and I think that the legislature expects of us, will require some additional staff. So with that, the legislation does change the way that our assessment is calculated that supports our annual budget. So our annual budget is supported by an industry assessment on acute care hospitals and health plans. I'll leave the details of this to a little bit later in the presentation, but needless to say that the legislation does seek to broaden that assessment to other types of industry entities, in this case, including pharmaceutical manufacturers and pharmacy benefit managers, who will be expected to contribute to the budget of the HPC, recognizing the expanded role that we will have in monitoring and providing oversight over those industries. As always, however, the HPC's budget is part of the state budget and will be set by the legislature and the governor through the annual state budget process. And so we'll be working with our partners in the legislature in this budgetary process to work with them and to model out what we think the actual budgetary impact will be in this first year and in the years to come, as many of these will be multi-year efforts. Professor Cutler.
Thanks, David. I just wanted to go back to one thing that you said and draw an analogy, which is about the need for particular expertise. The thing that we've done so far that has required probably the most detailed economic expertise is our cost and market impact reviews, where they really, really require an enormous amount of kind of deep economic knowledge and data and so on. And I think of the pharmaceutical issue as being basically equivalent to that understanding all the nuances. It's not just here's a drug and, whatever. It's like, you have to understand the PBM industry. You have to understand the role of rebates, and you have to understand the role of the insurer versus the company versus the PBM versus the manufacturer versus the distributor and the dispenser and all of that sort of stuff. And so we're going to have kind of, just as we've paid enormous amount of attention to making sure that like we are deep into understanding all of the sort of industrial organization type issues in the cost and market impact reviews and the economic issues there, not exclusively, but that's a big part of what we do. We're going to have to do the same here. And so I think it's going to have to come from a combination of both internal people as well as, the external consultants who we involve, because like this is just like it's super specialized and it's really, really important.
Yes, Professor Cutler, I absolutely agree. And I think your analogy is right on, and the balance of bringing on some of those external experts who have the decades of deep experience in this industry, I think will be very important for us to ensure that we have the credibility that we need to have in order to make meaningful policy recommendations in this space, and in a space where there is an intersection of very important dynamics of patient access, of healthcare spending trends, of innovation. These are a different set of dynamics than maybe some of the other things that we look at. And so I take your comments. Thank you. Dr. McGregor.
Hi. First of all, thanks so much for the really great summary of the bill, and certainly encouraging to see Massachusetts take this step in oversight of such an important part and large part of healthcare in the United States. So my question is around the out-of-pocket, sort of the copay caps that you mentioned for certain drugs. You mentioned that those apply to Mass Health, to the Group Insurance Commission, and there was one other. Did you mention employer-sponsored insurance or commercial insurance as a whole? Because one, I'm wondering, how does this apply to plans that are sold on the connector? And two, who are the groups of enrollees that are potentially left out of these copay caps? Is that clear to us at this point?
I will ask my general counsel to correct me if I'm wrong here, but I believe that the copay caps would apply to the connector plans. I think what we cannot apply this mandate to is the ERISA exempt self-insured plans. But Lois, correct me if I'm wrong on that.
That's correct. Any fully insured health plan licensed by DOI.
Okay, so would that mean sort of many individuals who are employed through a large company or organization wouldn't have the benefit of these caps?
If they're participating in a self-insured plan.
Okay.
That's correct. That's the sort of reach of our state statutory authority.
Okay. All right. I don't know offhand what percentage of enrollees might comprise, but I would imagine a fairly large share. I think other folks on this call might know. But
Alicia, I'm guessing it's probably about half of the privately insured, if just as a round guess, because almost all the big employers are going to be self-insured, and then some of the smaller ones. So it is not a trivial matter at all.
exactly. Okay, so I think that's definitely something that's important to note in this legislation. As good as it is to see these important drug categories be covered, I think it's a first step, but a good first step.
Yeah. And I would note, in many cases, where the state has made a mandate for coverage of the benefit, or in this case, a copay cap on the fully insured market, there are times when self-insured plans will follow that same mandate in their plan design. They're not required to, but they may. And so I think that may be something, Dr. McGregor, that we'll want to examine as this moves forward. Do we see that our self-insured plans actually following the lead here? And one of the things that I think we can help with here is we're required to evaluate this program. And if we can demonstrate that this is a benefit to patients, and that maybe this helps with medication adherence, that it actually helps lower long-term costs for these patients, that it may be in the in the interest of these health plans to actually help their patients get access to these drugs. That may be something that we can help demonstrate in our analysis and in our reviews to make the economic case that this should be more widely applicable.
Yes, absolutely.
So that concludes my portion of the briefing. I'm going to now turn it over to Kara Vidal, who's going to talk to us a little bit about health planning.
Thank you, David. Good afternoon, commissioners. Yes, so excited here to talk about another new responsibility under the law, and that is the revitalization of state health planning. This is something that the HPC has recommended in its annual cost trends report policy recommendations for several years. It's something we've also heard a lot of interest and support for at the cost trends hearings over several years as well. And so very exciting to see this new responsibility as part of the law. So we don't have, unfortunately, as clear and nice sounding an acronym here as OPA, but this law also establishes a new office within the HPC, and that is the Office of Health Resource Planning. I don't think we're ready to commit to ORP or OHORP but we will find a good acronym for that. And that new office will be charged with developing a state health resource plan. And per the law, the goal of that plan will be to promote the appropriate and equitable distribution of healthcare resources across the Commonwealth based on the needs of the population on a statewide basis and the needs of particular geographic and demographic groups. So specifically, the law states that the plan should assess the anticipated needs for healthcare services and resources over a 5-year period. And then the plan would assess the Commonwealth's current inventory of resources available to meet those needs and what future healthcare resources would need to look like in order to meet out projected need. And then based on those findings, the plan can make recommendations for the appropriate supply and distribution, both statewide and regionally, and can also identify priorities for addressing those needs. So the state health resource plan itself is very broad. It is statewide. There are a number of service lines that the law specifically directs it to include. And the law also contemplates a second kind of report called a focused assessment. And that would allow for a deep dive examination of a particular service line or geography, or, in other ways, allow for a more specific look at a topic or a policy. And specifically, the law says that those focused assessments can look at the factors that may be driving health disparities or impacting the accessibility of care. So that is the Office of Health Resource Planning. And then I've got one more slide that is somewhat related, and then happy to take questions on both. So in order to do this new work of the Office of Health Resource Planning and to achieve the law's larger market oversight and monitoring goals, we'll need timely, reliable data about healthcare resources in the state. And so to that end, that there are many changes in the law related to health resource data collection, but there are two that impact the HPC specifically. The first is that the law directs the Department of Public Health to establish and maintain an inventory of Massachusetts healthcare resources under the direction of the Office of Health Resource Planning. So a new role there in helping to provide direction as to what that inventory should include, priority areas for data gathering or collection. The law also states that state agencies that have a licensing function, a registration function, or that otherwise collect healthcare resource data should support DPH in that effort. And it also says that the inventory should be maintained in a form usable by the general public. So that's one. And then the second set of changes are related to the Registration of Provider Organizations Program, or RPO, which is the data collection and transparency effort that's jointly administered by CHIA and the Health Policy Commission. So before the passage of the law, as it's currently implemented, there is a registration threshold for that RPO program that says that it can only collect information from provider organizations with at least $25 million in net patient service revenue from carriers or third-party administrators. We've interpreted that from carriers or third-party administrators language to exclude Medicare fee-for-service or Medicaid fee-for-service revenue, which means that there may be entities who would meet the $25 million threshold if you included all of their revenue, but if they have a high public payer mix, they're excluded. The law changes that threshold to be $25 million in revenue from any payer. And so there are expected to be new registrants for the program, particularly those with a high public payer mix who were previously excluded. The law also expands some of the types of information that RPO is directed to collect. So there's new ownership and governance collection requirements, specifically regarding significant equity investors, real estate investment trusts, and management services organizations. And then finally, the law increases the penalty for noncompliance with RPO and with other CHIA reporting requirements in order to better enforce adherence to those requirements. So currently, CHIA can fine organizations that are out of compliance a maximum of $1,000 a week, and they have an annual cap of, I believe, $50,000. And that has been increased to $25,000 a week, and the annual cap is removed. CHIA can also report the fact of noncompliance to the HPC and DPH, and we can incorporate, and DPH can incorporate into their work that fact into, for example, cost and market impact reviews, licensure decisions, and DON application reviews. I'm happy to answer any questions I can.
You said a little bit more about the outlook, the time frame for the plan, meaning, am I understanding you correctly that the outlook in terms of projecting need is a 5-year outlook?
That's right. That's the State Health Resource Plan specifically defines a 5-year planning period. The focused assessments, I think, do not have a defined time period associated with them. And I don't think anything would stop the plan from looking out further if we felt we had the data and capability to do so, but it talks about a 5-year planning period.
Okay, and then presumably gets refreshed every 5 years at a minimum, or too soon to say?
I think probably gets refreshed every 5 years, could be refreshed more frequently. I think if that would be valuable, or maybe pieces refreshed at a time. But yes, in general, I think the expectation is refreshed every 5 years.
Thank you.
Dr. Cutler.
Deb, one way that I think about this is the hard part hopefully is setting up the structure. Like, for example, just to take one example, how many hospital beds do we need in different parts of the state, where, because we hadn't thought about it, the state didn't know how to do this during COVID-19. And because we didn't have a planning structure, we weren't able to do it during the Steward fiasco. So you want to set up a structure where data gets fed in, and then it gets projected. But then once you've done that, in principle, it can be updated continuously, because it's always keeping track of, okay, how many people are there in different areas, and how many hospital beds are there in different areas and stuff. So the hard part is setting up the structure and saying, okay, what are the facilities there? What are they capable of doing? Where is the population? What are the needs of the population? So on. And then once that structure is set up, then it's kind of like, running an app to then, get a new output on a particular thing that one's interested in. So my hope is that it won't be like, it won't be like we're complaining, oh gosh, it's 4 years in and therefore our things are stale, but we'll be like, gee, look, we built the machine now, we built this fancy technology thing. Now just, push the button to get the answer that we want in this particular question. And then it'll be able to pull that out.
Right, yeah, this is helping me kind of visualize the possibilities for having this tool. And I think what you're saying is, as pertinent questions arise, you can feed it into that structure and, update as needed. Very exciting. Thank you.
All right, and our last section of updates, I'm going to turn it over to Lois.
Great. Good afternoon, everybody. So the law does make a number of important updates to HPC's Market Oversight Authority, consistent with the Commission's past recommendations to keep pace with different healthcare market activity that could have an impact on cost and access, including activity that could have a destabilizing impact on healthcare in the Commonwealth. So first, the law expands the type of transactions that require material change notice filings and potentially cost and market impact reviews, so that in addition to the mergers and acquisitions and affiliations that we currently review, we'd also be reviewing as MCNs significant expansions to a provider's capacity, transactions involving a significant equity investor that result in a change of ownership or control of a provider or provider organization, significant sales or transfers of assets, including real estate sale leaseback arrangements, is referencing the sale of Steward Healthcare's real estate to the Medical Properties Trust, for example, which was not required to be a notice filed with the HPC. And finally, conversions of a provider from a nonprofit entity to a for-profit entity, and that would complement the Attorney General's authority under the charities law. Second, the law expands the HPC's authority in the MCN review process to collect information from significant equity investors and other parties to a transaction, including by allowing HPC to require substantial financial information, including financial statements and materials on the investor's capital structure. That must be required to be filed with the notice. Third, the law authorizes the HPC to require additional reporting after an MCN for a period of 5 years, so that we can conduct post-transaction reviews. And as you know, this is something that we have done, and this increases our ability to do so by allowing us to actually require the submission of data and information from the parties. Finally, the law provides that HPC may consider any related health planning data, as well as the size and market share of any significant equity investors in a cost and market impact review. And this gets to Dr. Cutler's point that the information that we collect in the health planning process can be used in connection with our market oversight authority in the MCN and CMIR process. Next slide. In addition, the law adds new healthcare market participants to the HPC's annual cost trends hearing process, requiring testimony from a number of different entities, significant equity investors, healthcare real estate investment trusts, management service organizations, pharmaceutical manufacturers, PBMs, in addition to state agency partners. The law directs DPH to consider in its DON application process the state health plan, the Commonwealth's cost containment goals, impacts on patients, including considerations of health equity, and comments and relevant data from CHIA and the HPC, including any CMIR report. The law seeks to really align the HPC's processes with the DON process by codifying DPH regulations, which toll the DON timeline for both the independent cost analysis that DPH conducts, the CMIR, and the performance improvement plan, so that the DON cannot go into effect for 30 days until after the final cost and market impact report or the conclusion of a performance improvement plan. And finally, on this slide, the law authorizes DPH to seek an impact analysis of an essential services closure from the HPC during its review. And I'll move on to the next slide if there are no questions. So there are a number of additional provisions in these laws, and I'll just summarize a few here. Incorporated, and this was certainly a recommendation that we have made in a number of cost trends reports. The law requires that the Division of Insurance consider affordability to consumers and purchasers of health insurance when it examines rates submitted for approval. DPH is now required to establish regulations and practice standards for licensing of office-based surgical centers, as well as networks of urgent care centers. The law now expressly allows projects that advance health equity that the Health Policy Commission may want to establish through the Healthcare Payment Reform Trust Fund. In addition, a major work effort of the HPC, we've engaged in the Quality Measurement Alignment Task Force. The law now codifies that statewide advisory committee, and HPC is now a core member of that. And last, but certainly not least, as David mentioned earlier, our industry assessment. The law does add pharmaceutical manufacturers, PBMs, and certain non-hospital provider organizations to the HPC and CHIA's operating assessments. We have mirror assessments, and those entities will join the hospitals, ambulatory surgery centers, and payers who currently support the agency. I think that wraps it up.
Any questions on the slides that Lois just went through? Well, seeing none, there is one final slide and one important other provision that I want to highlight for the board here today. The legislation establishes a new primary care payment and delivery task force. This new task force is a 25-member task force charged with studying and making recommendations to improve primary care access and delivery and financial sustainability in the Commonwealth. This is, in my mind, an incredibly important task force, and the work of this task force has the opportunity to make a really meaningful difference in the future of primary care in Massachusetts. The task force is charged with a number of important duties to make recommendations, including around establishing a primary care spending target, which is something the Health Policy Commission has recommended in numerous cost trends reports, as well as proposing and advancing new and innovative payment models that would increase reimbursement for primary care and support the advancement of primary care, as well as recommendations around supporting the primary care workforce. The Health Policy Commission is going to be co-chairing this commission along with Executive Office of Health and Human Services. And this task force has a really important mandate. As we're going to hear from in a minute, the state of primary care in the United States and in Massachusetts is in a state of extreme challenge. And the need for action and policy action to improve both the delivery of care and to support the primary care workforce is urgent. And so we at the HPC will be working to really support the work of this task force, dedicating our staff and resources and time to this task force. I expect that we will be moving with urgency on the mandates of this task force, along with our partners at the Executive Office of Health and Human Services. And I look forward to continually updating you on the work of this task force over the next year. Why is this work of this task force so important? Well, that is really the next agenda item and the remainder of our meeting today. So with that, I'll turn it over to Deb, Chair DeVoe, and we'll transition to the next agenda item.
Great, thank you so much.
I just see one question.
Commissioner McGregor?
Yes, no, I just wanted to just make one remark here. I didn't want this opportunity to pass because I think, like many of us, my head is still spinning a bit with the passage of this legislation, because I didn't think it was going to pass, but then over the holidays, I saw the news that it would pass, and so certainly still processing, but certainly very encouraged with the huge steps that this legislation makes. I just want to underscore how important the health resource planning piece is, especially to ensuring equity in the healthcare system and promoting equitable access to care. Now, I think we've all seen the closures, not just the closures of the Stewart hospitals, which of course were devastating in and of themselves, and they impacted some of our most vulnerable communities, the community of Dorchester in Boston and the rural community in Neshoba Valley. But we've seen the loss of critical service lines, including the loss of obstetric services over the last 7 years. I believe the number is actually, I think we've lost 6 over the last, since 2017, 6 or 7, if I'm not mistaken. Now, all of these losses are devastating to the entire system as a whole, but we absolutely need to have a sense of geographically how they impact neighborhoods and communities, because the impact is certainly not borne equitably, and there's certainly a lot of inequity in Massachusetts as a state. So the increased ability to track the supply of services, to track the supply of the workforce, and also to track big gaps will really bode well for the system and for our ability to ensure that residents of the Commonwealth have access to the services that they need. So a huge thanks to the legislature, a huge thanks to everyone at the HPC, all of the advocates, including the Health Equity Compact and more, who really worked tirelessly to ensure that that equity was at the center of this provision of the legislation. So thanks so much.
Thank you, Dr. McGregor. I think as you're doing, it's very worth pausing for a moment as a board, because I think all of the comments and the discussion on this topic have really brought to the fore how important this legislation is going to be, how focused it is on the key issues that are facing our Commonwealth now, and on the responsibilities that this brings to the HPC. This is really a very, very fundamental change in the role for our organization. I think that we're all recognizing that this is as a result of the fact that there's a belief that the HPC is an independent organization with very high technical ability, also has the ability to convene of the broad set of views that are going to need to be brought into these processes, every single one of them, pharmacy, planning, and the new primary care task force, and how important it's going to be for us to take on this responsibility and really rise to the trust that's been placed in us by the legislature. And I would underscore what Dr. McGregor is saying by how difficult it was for the legislature to bring this to fruition, and how I think it was commented at the signing that it was felt that 9 out of 10 people in that room just felt it simply wasn't going to be possible to make this happen. So I think very exciting on all of those points that you're making, Dr. McGregor, in terms of we now have this opportunity that the legislature has given our Commonwealth, and specifically to the HPC, to make a tremendous difference. And I think the urgency that Executive Director Seltz is highlighting is a huge part of this responsibility now. So much more to come. Very helpful summary of what is a complex legislation, and we really appreciate the team providing this summary. But now we can all dig in and focus on what this is really going to mean for the agency and for the Commonwealth. So big deal with a capital B and D. Other comments or any other questions from commissioners before we?
Chair DeVoe, I do have one more slide, and just to your point, this next slide is just a timeline with some of the important dates for this calendar year. The law will go into effect on April 8th. the board changes and the assessment changes that we discussed will go into effect on July 1st. Some of the initial recommendations from the primary care task force will come later this year. These are some of the effective dates just from the law itself. But throughout this year, we are going to be hard at work and moving with that urgency you just said to create the definitions, create the rules and the structures and the processes to make this law a really meaningful and positive influence on our healthcare market, our healthcare industry, and for the benefit of the patients and residents of the Commonwealth. I will be returning at each board meeting with a more updated version of a slide like this with a lot more detail. And you can expect much more implementation plans from staff as this year moves forward. The work has already begun, but it really begins now. Thank you.
Thank you. And our last topic, other than our executive director's report, is really focused on primary care in Massachusetts. And our commissioner, Dr. Maddie Castile, who is a primary care physician and whose role on the commission is to provide that lens, is going to introduce this topic for us. Let me turn it over to you, Commissioner Castile.
Thank you, Chair DeVoe. I was very excited when I saw the PowerPoint and that this has been an issue that all of us are struggling with, the decline of primary care, and which is one of our highest values of care. I think back about some of the comments that were made at the hearing where, you know, they lose 200,000 on a primary care, the most essential person to see the entry point of actually seeing patients, which has become very difficult for our communities. And certainly the wait time to actually get in has been incredible. And we know that having more primary care providers leads to better population health and lower cost. In Massachusetts, we're seeing that primary care represents a declining share of health spending, and we've seen a shrinking primary care workforce and persistent patient access issues, which can even take up to a year to get in to see somebody. So as part of the HPC's ongoing focus on examining the challenges Commonwealth healthcare workforce, the HPC team has explored what's going on with our primary care providers, what financial and day-to-day challenges they face. And in this report, they have offered some ideas for what we might be able to do to alleviate the pressures of this workforce. So with that, I'd like to have Dr. Sasha Albert, who is the Associate Director of Research and Cost Trends, to lead us through this amazing PowerPoint. Thank you.
Thank you so much, Dr. Castile. I'm pleased to be sharing with you all today our study on primary care in the Commonwealth. This work follows on our previous study of the Commonwealth's healthcare workforce and is part of our broader research agenda writ large on workforce trends and their implications for Massachusetts. So the work we're sharing today seeks to highlight underlying trends surrounding primary care provision in Massachusetts and to make recommendations that would support a revitalization of primary care in the Commonwealth. And before launching in, I just want to acknowledge my colleague Charlotte Burlingame, whose work was invaluable to this project and who will also be presenting some of our findings today, as well as the many agencies and organizations whose expertise really helped inform how we understood our findings, including the Executive Office of Health and Human Services, CHIA, Mass Health, League of Community Health Centers, Mass Medical Society, Mass Association of PAs, Mass Coalition of NPs, and many more, too many to list, as part of this introduction. Next slide, please. And one more. Thank you. So to start off, what is primary care? Primary care involves first contact care for unknown health issues, as well as wellness, prevention, and chronic condition management, provided often by clinicians who maintain long-term relationships with their patients and provide coordination with other areas of the health system. And primary care, as Dr. Castile teed up for us so beautifully, is unique because unlike other categories of healthcare, an increased supply of providers is associated with better and more equitable population health. And not only that, but a health system that is oriented towards primary care in the form of a high ratio of PCPs to specialists is associated with better health outcomes, fewer ED visits and hospitalizations, and lower costs. Next slide, please. However, primary care is facing many challenges in Massachusetts. Despite all the benefits I just listed, it represents a declining share of health spending, and we have high and growing rates of residents reporting difficulty accessing care, as well as an aging and shrinking primary care workforce, and among the smallest shares of both the current physician workforce in primary care and of new physicians entering the field. So with that, who provides primary care in Massachusetts? Next slide, please. Primary care in the Commonwealth, next slide, sorry, is provided by a variety of types of organizations. Most prevalent and perhaps most familiar models include hospital-affiliated practices, practices that are part of non-hospital affiliated provider organizations, independent physician-owned practices, and community health centers. And newer models include retail clinics, urgent care centers, virtual first or virtual only providers, newer concierge practices, and private or hospital affiliated practices that are operating in concierge models. As far as the workforce on the next slide, the core clinician types who provide primary care in the Commonwealth are physicians, as shown here in the blue, nurse practitioners, as shown in the yellow, and physician assistants in the orange. As of 2022, there were about 15,000 primary care providers in Massachusetts. And as shown on this slide, the share of PCPs that were advanced practice providers, that is NPs or PAs, grew from just over a quarter in 2018 to almost a third in 2022. Reflecting this increase, the share of primary care visits provided by NPs and PAs has also increased over time. On the next slide, we can see that this has occurred for both MassHealth members, as shown on the left, for 2019 and 2021, as well as for commercially insured patients, as shown on the right. And to say a little bit more about how this slide reflects the role of the advanced practice providers, this slide uses our claims data, which means we were able to reflect both visits billed directly to these three types of providers, as well as visits with clear incident to billing, that is, when care provided by a non-physician is billed under a physician's ID. And we do this to reflect the full extent of primary care provided by NPs and PAs. So we see that visits provided by PAs are in orange, visits with incident to billing are in the light blue, and visits provided by NPs are in yellow. And in both the MassHealth and the commercial patient populations, we can see by the growing share of each bar taken up by those three colors that primary care provision by NPs and PAs is on the rise. On the next slide, we turn to demographics. This slide shows the age distribution of these three types of providers in office settings, which we use as a proxy for PCPs. And we see somewhat different age distributions among physicians, NPs, and PAs. Physicians working in office settings are older, with 1 in 5 age 65 or older, as shown in the green portion of the pie for physicians. While NPs and PAs, by contrast, are relatively young. A fifth of NPs and a third of PAs are under age 35, as shown in the dark blue. On the next slide, we turn to race and ethnicity. In all three roles, we see an underrepresentation of Black and Hispanic clinicians relative to the state population. Here we have the distribution of the Massachusetts population on the left-hand side, and then we compare to physicians, NPs, and PAs. And we see that Hispanic and Black clinicians of all types, as shown in the orange and the yellow, respectively, are underrepresented relative to the population of Massachusetts as a whole. Just to give one example, 11% of the Massachusetts population is Hispanic, but only 5% of office-based physicians are. I'll now pass the microphone over to my colleague Charlotte Burlingame to discuss concerning trends we've measured in primary care provision, workforce, and access.
Thank you, Sasha. Good afternoon. Overall, we're seeing falling spending on primary care, as well as decline in physician entry into the field. I'm going to start with some broader trends on labor. Here we see during the pandemic, employment in physician offices in Massachusetts plummeted, illustrated by the dark blue line. This is due to layoffs, furloughs, and retirements, though employment in hospitals dropped to a far lesser extent, which is the line in the solid orange. This decline in office employment was much larger for Massachusetts than for the US overall, if you compare the dark blue line of Massachusetts to the lighter blue dotted line, which represents the US overall. The recovery of this workforce has also been much slower in the Commonwealth. Physician offices employment is barely above pre-pandemic levels compared to 10.6% growth for the US. Next slide, please. We've also seen slow growth in primary care spending. From 2017 to 2022, commercial primary care spending grew half as fast as spending for all other medical services. In other words, the share of all commercial medical spending on primary care has decreased over time, from 8.4% in 2017 to 7.5% in 2022. On the next slide, if we break out this slide into spending for children and adults, we see that this trend held true for patients of all ages. This graph illustrates commercial medical spending on primary care and other medical services for children to the right and adults to the left. Over this time period, primary care spending grew half as fast for adults compared to spending on all other things. But this dynamic is particularly striking for children. Primary care spending just grew 1/3 as fast for children compared to spending on all other medical services. Next slide, please. And it's not just that we have less spending on primary care, but we appear to have fewer total providers as well. This graph shows the number of physicians working in Massachusetts by setting. Employment of primary care physicians in direct patient care roles, which is the section of this graph to the left, barely increased from 2014 to 2020, just 2% over that time period, compared to nearly 13% growth in employment of other physicians. Put this another way, primary care physicians in direct patient care made up a declining share of total physicians, from about 27% in 2014 to 25% in 2020. On the next slide, and this is a concerning trend because while Massachusetts has a larger number of physicians per capita than any other state, you can see us to the far left of this graph, which indicates that we have the most physicians per 100,000 residents. When we sort these states instead by the per capita share of the physician workforce in primary care, we're actually 5th from the bottom, which is highlighted here in the orange. So this indicates that our healthcare system in Massachusetts really prioritizes and is oriented towards specialty care, which is troublesome because, as Sasha mentioned, research has found that a high ratio of PCPs to specialists is associated with better health outcomes, fewer ED visits and hospitalizations, and lower costs, which are the things that we as a Commonwealth are all trying to achieve. Similarly, research has found that in states like Massachusetts, where we have a large share of specialists, there tend to be more hospitalizations of Medicare beneficiaries, which may reflect their inability to access timely care in a lower acuity setting. Next slide, please. We're also not getting very many new primary care physicians. In 2021, we were 4th from the bottom on the share of new physicians entering primary care, right between Rhode Island and Kentucky. This is at almost 15%, and it's nearly 7 percentage points lower than the US average of 21.6%. Next slide, please. Additionally, our primary care physician workforce appears to be aging. The yellow bars show physicians providing primary care in office settings by age, while the blue bars show all physicians. And even though most of our physician workforce is fairly young, represented by the higher blue bars to the left, in office settings, nearly half of our physicians are 55 years old or older. Lack of new physician entry into primary care, coupled with this aging workforce, poses problems for PCP supply, as not enough young physicians are entering primary care as older ones retire. So, altogether, spending on primary care in Massachusetts is decreasing over time as a share of all medical spending, and primary care physicians are a shrinking and aging share of all physicians in the Commonwealth. Next slide, please. Now I'm going to discuss some of the concerning trends we're seeing related to access to primary care. Next slide. A survey by the Massachusetts Health Quality Partners has found worsening access to primary care each year from 2019 to 2023. This is not only a problem in and of itself, but it can also have adverse ripple effects, as shown in this diagram. Patients in the community being unable to access primary care in a timely way is associated with avoidable use of higher acuity, higher cost settings, such as the ED or hospital, and worse patient health outcomes. These effects are avoidable. CHIA's most recent MHIS survey found that 36.2% of Massachusetts residents with an ED visit in the past year reported that they could have been treated by a general physician if one had been available. And as we'll discuss more in a little bit more detail later, access issues are felt more acutely for different groups in the Commonwealth. Next slide, please. One way that access challenges manifest is as long wait times for a primary care appointment. Of 15 US metro areas, Boston had the second longest wait times for a new patient appointment for a physical in 2022 at 40 days, indicated by the orange bar. This was twice as long as the average wait time of 20 days across all of these cities, as you can see to the far right. Wait times for a heart checkup with a cardiologist or for an orthopedic surgeon to assess knee pain were shorter than wait times for a new patient physical by 11 days and 20 days, respectively. Next slide, please. In 2023, 41% of Massachusetts residents reported difficulty accessing care, an increase from 34% of residents in 2021. Many of the difficulties people in the Commonwealth reported might help us understand why access issues persist, even though we have a large number of PCPs. 13% reported difficulty because their insurance type wasn't accepted. 19% reported offices were not taking new patients. And nearly a quarter reported being unable to get an appointment as soon as they needed. Long wait times and access issues may persist due to other reasons as well, such as providers reducing their patient care hours, large panel sizes, and difficulty recruiting and retaining support staff. Next slide. Although we have a lot of PCPs providing direct patient care, we have about 101 per 100,000 residents. Access is not evenly distributed across the Commonwealth. PCPs are concentrated in a few counties, particularly those with urban areas. Despite Suffolk County having the highest number of PCPs per capita, wait times for a primary care appointment are long in Boston, as we've just seen. And we can imagine them being even longer in counties with fewer PCPs. So we have evidence of people in the Commonwealth not getting timely care, and we know that access to primary care is likely not equal across the state. So we're going to turn to ask, what are some of the consequences? Next slide, please. People who can't access primary care may have low care utilization as a result. Access issues are felt more acutely for lower income individuals in the Commonwealth. People in low median income areas were more likely to have no primary care visits than those in high income areas. And this difference is especially pronounced for children, which are illustrated by the yellow bars, where those in low income areas were 3 times more likely to go without a primary care visit than those in high income communities. Residents in communities with lower median incomes were not only more likely to have no primary care visits, but were also more likely to have no care utilization at all. Next slide, please. As noted earlier, patients being unable to access primary care when they need it may result in potentially avoidable use of the emergency department. From 2016 to 2023, about 40% of all ED visits were situations where a patient's condition could have been treated in a primary care setting or prevented entirely with timely primary care. This is illustrated by the red bars. Although not all preventable ED use is due to primary care access issues, it's certainly a driver. For example, a 2023 survey found that 2/3 of Massachusetts residents who went to the ED for a non-emergency condition sought care in the ED because they were unable to get an appointment at a doctor's office or a clinic as soon as they needed. And I'll note too that there are also persistent disparities in potentially avoidable ED use. As of 2023, Black, non-Hispanic, and Hispanic residents were found to be nearly twice as likely to go to the ED for a non-emergency condition compared to white non-Hispanic residents. And this suggests worse access issues for those groups. Next slide, please. So now that we've described current trends in primary care workforce and access to care, I'm going to turn it back over to Sasha, who's going to discuss the root causes of these challenges.
Thank you so much, Charlotte. So at a high level, primary care has become a less and less desirable and sustainable career due to a combination of two things. The first is relatively low reimbursement. That can make it hard for new graduates to choose primary care over specialties, can make it difficult to sustain small primary care practices as businesses, incentivize investment in primary care over more profitable specialties, and can limit practices' ability to hire and retain support staff. Second, and most immediately relevant on a day-to-day basis for our current PCP workforce, is high administrative burden, which can make the work of primary care unsustainable for providers and is a factor in burnout, reduction in patient care hours, or leaving the field entirely. Next slide, please. Start with reimbursement. The way that medical services are paid for arguably undervalues the cognitive, clinical assessment, and care management services that are at the core of primary care, and overvalues the provision of procedures. This slide shows Medicare physician revenue for two common specialty services, screening colonoscopy and cataract extraction, that take less than half an hour apiece, in comparison with physician revenue for an approximately half-hour outpatient office visit. And as this graphic shows, Medicare reimburses 3 to 5 times more for these common procedures than for outpatient office visits, which means that common specialty procedures may be able to generate more revenue in 1 or 2 hours than a primary care physician would receive for an entire day of caring for patients. Next slide, please. So that graphic was just Medicare, but the challenge is actually exacerbated in the commercial market. The bars here show the percentage by which average commercial prices exceed Medicare prices. So the shorter a bar is, the closer the average commercial price is to the Medicare price. And here we see the percentage by which commercial prices exceed Medicare prices for hospital outpatient services on the left, hospital inpatient services, physician specialty care, and primary care. And you can see that commercial payers on average pay for primary care physician services at pretty close to the Medicare rate, while specialists are paid almost 50% more than the Medicare rate, and hospital inpatient and outpatient services are paid close to double or even more than double the Medicare rate. So this is to show that the markup, so to speak, that services tend to get when covered by commercial payers over the Medicare rate barely exists for primary care. And this can make it hard for primary care practices to be financially sustainable and can disincentivize investment in primary care as opposed to more lucrative specialty services. Next slide, please. This dynamic can also have real impacts on physicians' career choices because new physicians often have significant amounts of debt from their education and medical training, and the difference in pay between primary care and medical specialties can be substantial. This slide shows median debt for new physicians in the orange, as well as median wage for primary care and a variety of physician specialties. As of 2021, about 70% of medical graduates had education debt with a median debt amount of $200,000. And the difference between the primary care and specialty incomes, especially in light of that level of debt, can make it hard for new medical graduates to financially justify going into primary care, even if they would prefer to. And to that point, an Association of American Medical Colleges survey of new medical graduates found that about 1/5 of those surveyed said that their level of education debt did in fact influence their choice of specialty. Another point, albeit harder to quantify, is that within the world of medicine, primary care is often considered to have less prestige than specialties. And medical students are often steered towards specialties that are seen as having more cachet. There's actually an interesting Kaiser Family Foundation piece that came out this week that talked about how challenging this more cultural aspect is for students who are aiming for careers in primary care. Next slide, please. This kind of dynamic is likely in play for advanced practice providers as well. This slide compares average annual income for Massachusetts NPs in inpatient settings, ambulatory specialty care, non-patient care roles such as research or academia, primary care, and community health centers. And you can see the financial disincentive to work in primary care or community health centers for that matter, as compared to specialty or inpatient care. And I just want to note that this may be especially the case because much like physicians, 70% of APRN graduates have education debt. And while we unfortunately didn't have such granular wage data for PAs, we would expect them to experience this dynamic as well. 80% of PAs have graduate debt in amounts of $100,000 on average, and we know that they likewise earn higher wages in inpatient settings. Next slide, please. However, the more significant root causes of workforce challenges in primary care are harder to quantify, and those are high administrative burden and poor job quality and sustainability. PCPs have responsibilities such as high-touch asynchronous messaging, such as patient portal emails, electronic health records, prior authorization, quality measure reporting, all of which can require substantial work outside of regular working hours. For instance, one study found that physicians spend almost 2 hours on administrative work for each hour spent seeing patients. And another study found that without adequate team-based care, providing primary care can take 27 hours of work per day. Likewise, a Mass Medical Society survey found that over 80% of physicians surveyed cited increased documentation requirements that were not always related to clinical care as an aspect of job quality in need of improvement. And these challenges can lead to burnout and job exit. For example, a 2022 survey of Massachusetts physicians found concerning levels of burnout and intent to leave clinical practice, especially among female physicians and physicians of color. And this is particularly worrying because, as we saw earlier in this presentation, physicians of color are already underrepresented in Massachusetts. And this can fuel a cycle of workforce sustainability issues in primary care, including larger patient panels for remaining clinicians and increased costs via high turnover. Next slide, please. Oh, excuse me, next slide. I spoke for 2 slides at once. In addition to facing the same financial disincentives to go into primary care as physicians do, advanced practice providers face the same kind of job sustainability challenges once they get there. For example, NPs cite stressful work environments as a top reason for considering leaving their jobs. And we've actually seen the share of Massachusetts physician assistants who are working in primary care decrease in recent years. So here we really want to emphasize the point that although NPs and PAs have had a growing role in primary care in Massachusetts, relying on advanced practice providers to serve as PCPs instead of physicians may not resolve challenges related to the availability of providers if we can't improve job sustainability in the field of primary care. The challenge is the job of primary care, not which types of clinicians are doing that job. Next slide, please. Additionally, we'd like to highlight that greater clinician workforce diversity would be beneficial for patients. As we discussed earlier in this presentation, Black and Hispanic clinicians are underrepresented relative to the Massachusetts population. And in addition to research that finds that patients are often more satisfied with their care when they and their care providers have similar backgrounds, there's also been research finding that racial concordance between patient and provider can be associated with lower spending. So there are a variety of reasons to aim for a more racially diverse PCP workforce. On disability, although people with disabilities represent a substantial share of the population, only about 2% of Massachusetts physicians and about 2% of NPs report having a disability. Increasing the representation of clinicians with disabilities may help to increase accessibility of care for patients, including if patients and clinicians need similar accommodations. Next slide, please. Finally, for this section of our work, the challenges that are currently facing primary care are significant enough that some groups have seen them as an opportunity, as an opening for new entrants into the field and for the development of new care models. On the ownership side, in addition to increasing consolidation of primary care into large health systems, we've also seen an increase in ownership of and involvement in primary care by entities such as large retailers. Increasingly common care models include partly or fully virtual care delivery, as well as the adoption of membership-based concierge care among both traditional practices and newer startup entrants. Next slide, please. Concierge models of care delivery in particular are becoming increasingly common. They offer improved job sustainability for clinicians, but may also contribute to broader patient access challenges. Concierge practices are similar to conventional primary care practices, but have much smaller patient panels for clinicians and charge their patients high membership fees, usually thousands of dollars a year, alongside accepting insurance, which provides practices with predictable revenue and the ability to hire enhanced administrative support, while at the same time offering enhanced access to care for members. However, the small patient panels and costly membership fees can contribute to overall access challenges by limiting who can access concierge clinicians while potentially concentrating patients who can't or don't want to pay for concierge membership in increasingly overburdened conventional practices. The prevalence of concierge primary care has increased over time, and when a clinician in a conventional practice shifts to the concierge model, most of their patients will need to find a new PCP. But I want to acknowledge that we wouldn't be seeing these kinds of changes in primary care, the new entrance into the field, the shifts towards concierge care and other models, if the conventional system was really working for patients and providers. It's clear that the concierge model appears to have some real job quality benefits for PCPs, and I would suggest that the promising aspects of these new models maybe could be replicated in more traditional practices with changes to how we pay for primary care. Next slide, please. So as part of this presentation, we wanted to be sure to bring some focus to our community health centers, which are an essential source of primary care for patients who are medically underserved or may otherwise lack a regular source of care, and which are experiencing the same staffing patterns in primary care generally, as in primary care generally in Massachusetts, but with even greater financial and job sustainability challenges. So while we've seen NPs and PAs take on a growing role in primary care statewide, in our community health centers, they've actually outpaced physicians as care providers in recent years. So on this slide, we have physicians in the blue and advanced practice providers in the orange and yellow. And you can see that which bar is higher has switched over time. And this is for all types of care, not just primary care. But as you can see by the overwhelming majority of physicians shown here being primary care providers in the light blue, primary care is a substantial portion of what community health centers provide. Likewise, on the next slide, we start looking at the financial side. Here we're looking just at federally qualified health centers due to the types of community health centers we can see in our claims data. Federally qualified health centers are a subset of community health centers. And we're looking at commercial payment for outpatient office visits, comparing federally qualified health centers to offices for the three types of physicians who are providing primary care. So we see that federally qualified health centers receive substantially lower commercial payment rates than offices do for the same primary care visit, for the same CPT code, to get into the weeds a little bit, regardless of which type of clinician is providing the care. Since we saw earlier in this presentation that average commercial payment rates for primary care services are pretty close to the Medicare rate, this would suggest that federally qualified health centers actually receive less from commercial payers than what Medicare would pay. So this is all to say that even within the relatively low paid world of primary care, federally qualified health centers receive particularly low commercial reimbursement. As of 2022, about a quarter of Massachusetts community health center patients were covered by commercial insurance, while almost half were covered by Medicaid and 14% were uninsured. And it's our understanding that, at least in part related to the unique public funding arrangement for services at community health centers, Mass Health could be considered their best payer, while commercial would be less so. Next slide, please. But between community health centers' relatively low commercial rates and their payer mix, it's unsurprising that they would have a hard time competing on wages. According to the 2023 CHIA Workforce Survey, non-competitive salary and workforce burnout were top workforce challenges reported among community health centers, where staffing shortages can mean that current staff work extra hours, which can then create a cycle of turnover, overwork, burnout, and further turnover, which can undermine effective team-based care and morale. Community health centers do also have unique opportunities, though, in the form of loan repayment and other retention programs, which have been effective at helping staff driven by the mission of caring for our underserved residents stay in those roles and providing that care. And just to highlight, about 2/3 of advanced practice providers surveyed at community health centers have reported participating in a loan repayment program. And about 1/3 of advanced practice providers surveyed reported that loan repayment program participation would motivate them to work at a community health center. Though I do want to acknowledge that retaining clinicians who finished out their work commitment associated with being in a loan repayment program can sometimes be a challenge. So where do we go from here? Next slide, please. Primary care is in a challenging position in Massachusetts because the work of primary care has become unsustainable. To repair primary care in the Commonwealth, we have 3 main areas we'd recommend receive attention: reducing sources of administrative burden and burnout, strengthening the primary care provider pipeline, and increasing spending for primary care. Next slide, please. On reducing sources of administrative burden and burnout, we recommend that payers limit or eliminate quality measures that may be duplicative of those represented in the Commonwealth's aligned quality measure set. We also recommend payers design their quality measure billing and coding and prior authorization requirements to minimize clinician administrative burden, for example, to reduce the likelihood of needing claims reprocessing. For healthcare delivery organizations, we recommend increasing wages to support hiring and retaining more effective care teams. And while we know the Commonwealth is interested in investment in primary care, we want to note that the Commonwealth should approach adding any net new responsibilities for PCPs that may come with that investment with caution. Next slide, please. On strengthening the primary care provider pipeline, the Commonwealth could consider restoring Medicaid funding for graduate medical education, particularly with a focus on training all types of primary care clinicians, so advanced practice providers alongside physicians, and particularly in community-based settings. Additionally, as we discussed for community health centers, workforce investments such as loan repayment programs and residency programs for advanced practice providers have been effective ways to remove barriers and bolster retention, and we should continue and strengthen these types of programs. Commonwealth could also facilitate continuous practice for PAs by shifting the supervisory requirement for physician assistants from individual physicians to the PA's employer or practice, so that when a supervisory physician leaves or retires, the organization does not also lose the PA until they can find a new physician to supervise them. Next slide, please. On spending, we note that there's a need for increased investment in primary care and that it should involve both shifts in payment models and in the balance of medical spending in the Commonwealth. Most notably, we recommend a shift towards capitated models for primary care to provide more stable and predictable revenue and to facilitate staffing and infrastructure investments that would allow for more support for PCPs as well as more comprehensive care delivery. And we note on this slide that the recent adoption of primary care subcapitation by MassHealth is one way that this is currently being done. On the next slide, further illustrating ways that this could be done, several other states have taken steps to increase investment in primary care, setting targets for the share of medical spending that would need to be on primary care, ranging from 10.7% in Rhode Island to 15% in California. So there are models that we could learn from on how we might approach increased primary care investment for Massachusetts. Next slide, please. As was discussed earlier in this meeting, the Health Policy Commission will, in partnership with EOHHS, co-chair a new task force that aims to study and make recommendations to improve primary care access, delivery, and financial sustainability for the Commonwealth. And we're hopeful that the research we've shared today, as well as our recommendations, can help inform this important discussion, as well as provide a set of areas for the task force to explore further as it gets underway. Next slide, please. Our full primary care report is now available for you to read on the HPC's website. Thank you so much for your time and attention today. I'd be happy to answer any questions and looking forward to continuing the conversation this afternoon.
Thank you so much, Dr. Albert. And what ideal timing for issuing this report and beginning this discussion as we launch into the other activities, as you mentioned. Questions from commissioners for Dr. Albert? Dr. Cutler?
That was a terrific report. I wanted to pick up on one of the themes, which is about alternative payment models, because one of the goals, certainly behind the AQC and behind a lot of what the state has been pushing plans to do with their AQCs, is that it would increase the relative demand for primary care and reduce the demand for specialists accordingly. And we've gone through phases where we've seen some of that, like where the big health systems buy a lot of primary care docs because they understand correctly that they're both the way to get the patients and also a way to keep the sicker patients out of the hospital and so on. But then you were, so that was all fine, but then you were saying, well, I think what you were saying is, maybe that hasn't gone far enough, and that there's still, maybe they want them, but their compensation is still on a fee-for-service basis and it's too low, or maybe they don't really want them. They used to want them, but they don't really want them. I'm just trying to reconcile the kind of, Massachusetts has more alternative payment model use than anywhere in the country. At least we used to, as a couple of years ago when we tracked it. And so how is that not having some type of effect on the demand for pay for work conditions of primary care docs?
Yeah, thank you. I think the point you raised about fee for service is a big part of the picture, that if the only activity of primary care that's paid for is when the clinician is in the room with the patient, there's a lot of work of primary care that doesn't cover. And that doesn't cover the hours of patient correspondence through MyChart and other portals. That doesn't cover negotiating with insurance companies, and it becomes challenging to have an adequate care team when only part of the work is covered under the current payment structure.
Sasha, if I may add, I just wanted to say that I have colleagues who work 30 hours a week seeing patients, and they are 50 hours a week doing the rest of the paperwork that's there. So the idea of decreasing your hours doesn't decrease your hours of the things that you do.
Very, very helpful. I think exploring what has worked and what hasn't worked about alternative payment models be an important focus of this next phase of work, and understanding Dr. Castiel's point about the administrative burden and what can be done beyond the recommendations stated here is going to be key. Commissioner Mahania?
Yes, I just wanted to answer Dr. Cutler's question. So in my prior life, I was the CEO of the Lynn Community Health Center, and still see patients there. But one of the things that happens is that MassHealth, MassHealth moved to this capitation model, so we got a monthly fee. But that still meant that 50% of the rest of our patients were still in some kind of fee-for-service chassis. So we still had to maintain a whole fee-for-service chassis as we're building out these support mechanisms to do team-based care. So part of the difficulty is that I think there has not been for any particular practice an overwhelming proportion of their patients that are in a alternative model. So Blue Cross Blue Shield did pioneer this, but A, they weren't really followed by other commercials, and B, the incentive wasn't big enough. Like if you want practices to really go into some kind of incentive-based model, you have to start putting incentives around 15, 20% of your total compensation. And most places don't do that. So I would say that that's number one. And then number two, it's difficult in integrated systems there's no mechanism, right, to force somebody to, once they get their incentive or their reward, there's no mechanism to force that money to go into primary care if other places are still generating more revenue per investment, right? So that's also something that plays into it.
Can I just ask one quick follow-up? At a place like Lynn Community Health Center, I understand MassHealth must be the dominant payer. What's second after that? Like which plans? If you said where would you change in order to change it? I mean, if you say Blue Cross and Harvard Pilgrim, that's one thing. If you say Medicare, that's a different.
Yes, so you're correct. So the number 2 was Medicare, and when I was there the last 2 years, we'd actually joined a version of Medicare that went toward that was a heavily incentive-based system that looked like a capitation model. But yes, number 2 was Medicare.
And just to add, Dr. Cutler, while Massachusetts was certainly, leading the pack in terms of APM adoption, we really plateaued in the commercial space, about 6 years ago and have not really moved that dial up at all.
But it sounds like for the community health centers of the world, it's really more about Medicare and Mass Health. I mean, the Medicare has the ACO program. I mean, we should take this offline, but I'm just sort of curious about, why between Mass Health and Medicare, that's not big enough. I understand for sort of a practice in a not so heavily Medicaid and not so heavily Medicare setting, why you then have to, why then the 1/3 penetration in the commercial market is really difficult, but I'm not sure I understand the other part yet. But again, I'm happy to take this offline.
Yeah, I think it's a very important thread to pursue in terms of what does this look like from the primary care practitioner, physician or nurse practitioner through their lens? Because even where a practice may have programs for alternative payment with Medicaid, Medicare, and commercial, they're all different. So back to the point that Commissioner Mahania was making earlier, even if those are in place, if they're not lining up, that can create tremendous complexity. So I think looking at that through the lens of the the provider is going to be very helpful. Commissioner Kaufman?
Yes, thank you. So I just had a question as far as like when the research was done, when I took a look at the map of the availability of PCPs across the Commonwealth, it is striking. That it's 158.1 per 100,000 patients in Suffolk County, and it's much lower like in Bristol County. But my question is, was it portioned out so that you could see that because we also took a look at the ages of PCPs and the number of PCPs, the ages. So when I look at it just as like a consumer, I would think, okay, maybe a lot of those PCPs in Suffolk County have been in practice for a while because they can afford to live there. As opposed to, so not only are we losing the younger people who are going into, to be physicians, they don't want to be PCPs because of the cost, because the salary isn't good, but they can't afford to live in Massachusetts. I mean, in many areas of Massachusetts. So I think I was just wondering if maybe housing was looked at as well, because I know I have friends who are married, they're both physicians, they're both in specialties, but they live in New Hampshire, and they work down here. And it was like, we can't, with our student loans, we can't afford a house like where I grew up, so in like the Lexington, Arlington area this is where they grew up. But, they're like, so we're living in New Hampshire and working here in Massachusetts. So I was just wondering if maybe that had been looked at.
Yeah, that's a very important point. I mean, we know that Massachusetts is a very high cost of living state, and in our previous workforce report, we actually have some graphics on cost of living relative to what some other types of care providers are paid. We didn't do that direct comparison for this work, but it is a very important point that, in addition to the sort of financial disincentives to go into primary care, the level of debt that new medical graduates are entering the workforce with, they're also facing just a incredibly strapped housing market and a very expensive place to try to live, and that could certainly drive some of their decision making.
Sasha, do you remember if that came up in any of the CHIA workforce surveys?
Cost of living?
Housing or childcare, as challenges?
Yeah, it's a good question. I can investigate.
Thank you.
Commissioner Cohen?
Yeah, David, I can tell you, having worked in Metro West, trying to find housing for primary care physicians in Metro West, new primary care physicians, is impossible. Want to note the importance of, first of all, Sasha, great report, really timely and just right on the mark. But I want to just mention the importance of primary care in relation to behavioral health, because it's primary care where early screening is happening for both mental health and substance abuse cases. And it's also where a great deal of treatment is taking place through prescriptions or also with referrals to behavioral health practice. And, in the behavioral health side, we've been pushing for integrated care models that primary care and behavioral health to lower the cost of healthcare for patients. But if we don't have primary care practitioners to lead those efforts, behavioral health is going to hurt. And the time it takes to get a behavioral health appointment or to get an appointment with primary care can very often result with those folks having to go to emergency rooms because of the dimensions of their disorder increase. So I just want to raise that point, and my hope also is that the task force includes that as part of their focus when they begin to look at the primary care.
Thank you. Yeah, that's a really important point. And I think this gets back to some of what we touched on the importance of adequate care teams and the sort of the challenges of standing up adequate care teams given the way that primary care is paid for currently.
Other comments or questions from commissioners?
I have a question. First of all, thanks so much, Dr. Alpert, for your presentation here. It was very eye-opening. One thing that really struck me was the slow increase or the slow bounce back from the COVID years in terms of primary care physicians being employed in physicians' offices in Massachusetts compared to the rest of the country. And so that chart on that graph was very striking and concerning, but it also reminded me that that period coincided with, for example, the acquisition of Atrius Health by Optum, and also that with the recent announcement that Mass General Brigham primary care doctors are filing to unionize, they cited not only burnout, but also the corporatization of care as one of the reasons for them wanting to unionize. And it's making me wonder how well we'll be able to sort of assess the impact of sort of increased corporate actors, for-profit actors in the primary care space, the extent to which they are deteriorating the work environment for primary care docs and keeping staffing levels as they are, which, is playing a big part in the fragmentation of care, the long waits. I myself am experiencing it, and certainly since COVID and beyond. So just putting that sort of a broader question out there. I don't know to what extent the new sort of healthcare sort of resource and planning sort of mechanism that we have, how well we'll be able to play a bigger role there.
Thank you. I think that's a really important and timely question. I mean, we know from from exploring our registration of provider organizations, that about half of Massachusetts PCPs, at least the ones that report to RPO, are affiliated with just 4 provider organizations. So I think that's, what everything you said really, really speaks to this point, that we need to better understand this. Thank you.
It's a great point, Dr. McGregor, and I want to think more about that, and I think you've laid out some suggestions there. I will note that the full report does talk a little bit more about some of the trends in both consolidation in primary care into the larger systems, but also the trend of private equity investment in primary care as well. And some of those dynamics are examined in the full report.
Yeah, and I agree. Very important point also that you raise. How are we different from other states, and what can we learn from that? And I think this fact base is going to be extremely useful for the task force as a jumping off point, because that information, I think, is always very helpful. There are aspects of the primary care crisis that are nationwide, but then there are aspects that are very unique to Massachusetts. Commissioner Foley?
Yeah, thanks again for this amazing and scary report. I mean, I think just recalling the Health Policy Commission, our cost trends hearing, where we heard Governor Healy and other state leaders identify this as a significant issue, and looking forward to see what's in store for the next couple of weeks over the budget being released and the upcoming legislative session around dealing with the issues that are identified in this report. So clearly a critical issue that I see feels like there's growing consensus around needing some work to be done to address it. And I just think, just on the second point, I think it's just highlights again our need to continue to focus on the workforce issues. That we had that great report, and we had the hearing on the impact of the workforce, and it hasn't gotten any better. It's probably gotten worse since the last time we sat down and reviewed that report and had the great hearing and heard from some of the leaders on this important issue. Every space I go to, it continues to come up. Every level of job within the healthcare industry and the crisis level that we're at. So I think this just reinforces the continued need for this commission to focus on this issue, on its impact on cost and quality in our healthcare delivery system. And so kudos to the commission for producing this report. And I just want to reinforce the importance to stay on this issue that's really impacting all of us and how we interact with our healthcare system.
Thank you.
Other comments or questions from commissioners? Dr. Albert, any closing comments?
No, I think the commissioner said it better than I ever could. Thank you so much.
Great. Well, with that, we are ready to turn to our executive director's report.
Thank you, Chair DeVoe. We have a very brief executive director's report for this meeting. First, want to provide an update on material change notices since our last meeting. And for that, I'm going to turn it right over to Kate.
Thank you, David. I'm going to provide our regular update very quickly. So as you all know, we have been collecting material change notices since 2013 and analyzing those. We are now up to 184 provider transactions that we have reviewed, with physician group mergers and acquisitions and contracting affiliations being the most frequent, followed by formations of contracting entities. Next slide. HPC staff are also continuing the cost and market impact review of the proposed affiliation between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty physicians. The next slide shows the timeline for our review. As shown here, we are in the time where we are working to complete our analyses, and we expect to be releasing a preliminary report very soon. And on the next slide, you see that since our last board meeting, the HPC has completed review of 2 notices of material change for which we elected not to conduct a cost to market impact review. First, the proposed acquisition of Springfield Anesthesia Service, which is a privately owned physician practice located in Western Massachusetts, specializing in anesthesia delivery and employing over 50 anesthesiologists, by Baystate Medical Practices, which is a subsidiary of Baystate Health, employing over 1,000 physicians and advanced practice providers in Western Massachusetts. Springfield Anesthesia is already the sole provider of anesthesia services at Baystate hospitals. That organization would be wound down following the transaction. And in our preliminary examination, we found that the transaction is unlikely to have a substantial impact on spending, quality, or access, given that Springfield Anesthesia is already a contracting affiliate of Baystate and already provides all anesthesia services at the Baystate hospitals, which would be anticipated to continue after the transaction as well. Second, we reviewed the proposed acquisition of Commonwealth Pathology Partners, which is a private practice pathology group employing 16 clinical and laboratory pathologists and additional pathology staff by Mass General Brigham. CPP currently provides all professional pathology services at Mass General Brigham's Newton Wellesley Hospital and Salem Hospital, as well as limited pathology services at other MGB hospitals. Under the proposed transaction, MGB would offer employment to the CPP pathology staff, and those providers will continue to provide services at MGB hospitals in a similar manner to today. So similar to the previous transaction, the Baystate Springfield Anesthesia transaction, in our preliminary review, we found that the transaction is unlikely to have a substantial impact on spending, quality, or access, given again that these providers are already contracting affiliates of the MGB system, and they already provide services at MGB hospitals in a similar manner to what is anticipated through this transaction. And on the next slide, you'll see that finally the HPC is currently reviewing one other material change notice right now, in addition to the cost market impact review, which is the proposed acquisition of Vibra Hospital of Western Massachusetts, which includes an inpatient long-term acute care hospital and a skilled nursing facility by Everest Hospital LLC, which is a newly formed Massachusetts corporation in coordination with Milk Equities LLC, which is a private investment vehicle with ownership interests in other nursing facilities. And I will pause there in case there are any questions before I turn it back over to David.
All right, seeing none, I have just one final slide to share with you, commissioners, and with our audience viewing this online, which is to announce that we are currently accepting applications for our HPC Summer Fellowship Program, now entering its 11th year. Each summer, we bring together exceptional graduate students from across the country who are passionate about health policy and offer them an incredible opportunity to learn about everything we do at the HPC. These fellows will join a department for the summer and help to develop a project from start to finish. And they really do become a part of our team, and they contribute so much to the agency over the summer. We've included an example of some of the projects that last summer's fellows worked on here. And we also have a report that we produce every year on the projects that each of the fellows do. Our 2024 Summer Fellowship Report is on our website. We also provide opportunities for our fellows to connect with staff from across the agency, as well as key stakeholders, and including some of our commissioners. So thank you again, and thank you in advance, and members of our advisory council. This program runs for 10 weeks from June 2nd to August 15th. And this year will be a hybrid format with fellows working alongside our staff in office and virtually. So our applications are due by Tuesday, January 21st. So coming up very quickly. We encourage all interested students to apply, and commissioners, please share this with your networks. This is a wonderful program that provides so much to us, and also really helps develop the next generation of health policy experts. that is the end of my executive director's report. I'll turn it back over to you, Chair DeVoe.
Wonderful. Thank you so much. Any other comments or questions from any commissioners before we move to adjourn? I want to mention that our next board meeting will be on Thursday, February 27th at 12 o'clock. Let me pause there for any other questions or comments. Seeing none, we
would
will.
just,
Excuse me. Yes.
Yes, I just want to add that I'm likely going to be the designee from UHHS to co-host with David the task force, and I think we're just really excited about this. Where we've already been meeting with David and his team, and we're hoping to move this as fast as possible because we know this is a crisis. But we really look forward to having the commission's support and also to updating you as to what our recommendations are as we go. But this is a very exciting moment for us and for HPC, and I'm very excited to get to know David even better.
Well, so glad to hear that. Thank you for taking on that leadership role. And I think I speak for all of us when I say that we couldn't be more excited about the outlook and the opportunities that the new legislation has created. So thank you. And with that, we will adjourn for today. Thank you, commissioners, and thanks to all who joined online.
Thank you.